people who use drugs to the point where it's sabotaging their lives, for them, in some way, there's a rationale to it. And it really is a trade-off because it makes their life so much more bearable.
Dr. Sally Satel, thank you for being here. You're a resident scholar at the American Enterprise Institute, and thank you so much for writing a chapter for my American Family Diaries volume. Your chapter is titled, "Why Do People Use Drugs?" And I have a bunch of questions about that. But before I begin, would you like to tell us a little bit about your work at AEI?
Well, sure, but I'll first mention why I think I know why people use drugs, and that's because I'm a psychiatrist and I specialize in addiction. So I've been treating and talking to people with drug problems for a long time. And so at AEI in general, I work on issues that are at the interface of medicine and culture. And I consider addiction, which has traditional medical components, but also social components and psychological components, to be an area that fits well under my umbrella, especially because one of my interests is how science and medicine can be politicized. And in some ways, I think the problem of drug addiction is.
Right, and that was so fascinating because that was a dominant theme sort of your chapter with the volume. So in the chapter, which I must say is beautifully written, you have all these stories, and I'll talk about that. But you talk about a dominant narrative surrounding addiction, which seems to be the idea that, as outsiders, we view addicts as being sort of not in control. And, it's like a brain disorder, and there's no way that they could change their behaviors to get off the addiction. But at the same time, you also say that neurobiology is not destiny. So can you expand on that? Can you tell me a little bit about, where that comes from?
Yeah, well, as you mentioned, I guess the prevailing narrative these days is not merely that addiction is a disease, and in many ways you can think of it that way. It's certainly a pathological behavior that no one who wants to have. And it's also a behavior for which professionals, psychiatrists and psychologists, can be helpful, and we use medication. But now it's being referred to as a brain disease. Actually, this is a label that's been used for over 20 years now. It originated with the National Institute on Drug Abuse. And I personally find it far too reductionist. Now, of course, the brain is involved in addiction. Why would people use drugs otherwise? But it's rarely enough to explain this very complicated phenomenon. Now, I should say I understand why the National Institute on Drug Abuse and many of my colleagues want to medicalize addiction to the extent that they have. And I think their motives are really benign, and I agree with them, which, for example, it's to get drugs and people who abuse them out of the criminal justice realm and into the therapeutic one. I understand that. They want to get more funding for treatment and research. Well, so do I. They think that it can reduce stigma associated with addiction. The data show that it doesn't. Plus, one has to think more subtly about what it is you want to destigmatize. Certainly an individual should always be treated with respect, definitely in a medical setting, and hopefully they elicit compassion from others, but there still has to be accountability when people commit crime. So that particular aspect, I think, deserves more thought. But again, all those motives are very noble. But I think we can achieve them in other ways, ways that don't involve perverting really the essence of what it means to be addicted, which, as I started to say, plays out on many different explanatory levels. One is the level of the brain. It's just that one, the circuitry and neurotransmitters, are not really the one that is most relevant when you're a clinician and a patient or a policymaker. In those cases, I find that the psychological level, the social and behavioral levels are far more informative when it comes to treating people and when it comes to making policy.
Perfect. So this gets me to our volume, which is focused on ethnographic research or qualitative surveys. And again, you mentioned in your chapter that if we want to help sustain recovery, then face-to-face engagement yields insights. How does that work with addicts? Why do you think ethnographic research or qualitative surveys could play a role in helping us address opioid addiction?
Well, because it goes to the core of addiction, which I think is underappreciated. And that's the concept that people use drugs for reasons. Right. That drugs are not, in and of themselves, this rapacious chemical that just takes over the brain. And in fact, consistent with the brain disease concept, the phrase, the hijacked brain. The drugs come in and they hijack the neurocircuitry, and of course they exert some control, and no one for a minute is saying that it's easy to just give up drugs.
Right.
It's very difficult, both because the drugs do certainly exert a neurochemical pull. I mean, people become they crave intensely, and they go through withdrawal symptoms that they want to avoid, and hence keep using often. But again, that's not the whole picture. And for example, I worked in a methadone clinic for many years. If the problem were simply that people couldn't tolerate the withdrawal from opioids, for example, then everyone should be fine with a few doses of methadone, right? Right. Because they're not in withdrawal anymore. But we find that the patients will often continue to use other drugs for quite a while, even though they're much more stable than they were before. But there's continued use of other drugs. Why is that? And it's because, again, people want to alter their consciousness, but not because it's fun. Sure, maybe some people certainly do enjoy even hard drugs recreationally, and to be honest, we don't see them because we as clinicians don't see them because frankly they can control their drug use.
That's right.
But people who use drugs to the point where it's sabotaging their lives, for them in some way there's a rationale to it, and it really is a trade-off that to them for a while is worth it because it makes their life so much more bearable.
That's right.
And they're in a lot of psychic pain for various reasons. And you can talk about that at the individual level, and I did write about some people in the chapter. You can talk about that on a communal level, where sometimes entire communities are in anguish, and that's where epidemics come from. So without understanding that, it's very hard to scale up. It's also very hard as a clinician. I'm not scaling up. I'm as individualized as you can get. And so that has to direct me.
Yeah, and so you write about the stories that you hear of the people who are coming into your clinics. I think one story you talk about, the two men, Zachary S. you call one, and Zach R. And then also the Vietnam veteran story. And I think those stories are really enlightening because you realize that people get into addiction for a reason, and then they can also, in some of these cases, pull themselves off the addiction. So I would love to hear about that, because I think listening to those stories could be very informative about how we help people sort of move forward and find a way out of this abuse.
Well, start with the Vietnam vets, because that's kind of a group, and then I talked about those two individuals. The Vietnam veteran story is really fascinating, and most of the research has been conducted by Lee Robbins from Washington University. I think her papers came out in the early 70s. So a problem arose, or at least Americans became aware of a problem that was going on in Vietnam in about 1971, which was extensive use of heroin and opium by the GIs. Yeah. And the Army itself came up with estimates that ranged between 15 and 25% of soldiers were actually addicted, not just used drugs, but were addicted. And clearly that's an area, I mean, Southeast Asia, where you get the best stuff. And, but why were they using it? I mean, you can have the best stuff, not use it. So what made that appealing to the men? And the two main reasons were, believe it or not, one, and this is probably not the primary one, but intense boredom. I mean, you're at the base most of the time. It's boring as heck, but this is the kind of boredom that's interspersed with terror, because then you're out in the jungle. And I'm sure some men were suffering post-traumatic stress disorder. And there was, I think at that time, also a bigger problem of it, just intense demoralization. People, including the soldiers, were very much questioning what we were doing there. And, you know, war is hell. And you can't think of a better way. And they missed their family. And I mean, you could just imagine all the stresses on them. And there was all this high quality drugs that was denormalized. I mean, that's the other thing. I mean, it would be different for me to go pick up some heroin, but if everybody at AEI were doing it, it wouldn't be such a big deal. So it was pretty much accepted. It was widespread, and it served this function of helping these guys cope. And of course, I say guys because there weren't many women in the war then. And so when President Nixon became aware that there was so much drug use, he was very nervous that these men would export it with them when they came home. And there was already significant heroin use, especially in big urban settings. And so they came up with this fairly ingenious plan, or at least it had an ingenious name, called Operation Golden Flow, where they would not allow anyone to come back to the States when their tour of duty was up until they could prove through a urine sample that they weren't using drugs. And if they were, they had a week to detox or some time, and then they would return. And so when that news got out, the vast majority of people just stopped using drugs and were able to come home. And stayed drug-free, or at least opioid-free, heroin-free. That would be what they would use for the 3 years that Lee Robbins followed them. Now, if the term, there was a classic term, once an addict, always an addict, if that were really true, then they would just start using drugs when they came back.
Absolutely.
But then the question is, well, we know why they used drugs while they were there. Well, why did they stop using drugs when they came back? Well, the whole context changed, and context is so key for understanding drug use. It wasn't available easily, and in order to get it, you'd have to travel to some pretty bad neighborhoods. It was bad quality anyway. But they had lives. They had wives. They had kids. They resumed their old identity. They had work to do, and also what behaviorists would say, the cues weren't around anymore. The environment changed. Not only did the psychological need change, and maybe even the social need, but the actual triggers for craving were really not there anymore. Your buddies weren't there. I mean, there's the classic people, places, and things you're supposed to avoid when you're in recovery, because those triggers will, on a totally unconscious level, start to generate craving. And you have to learn how to resist that craving, but some people are better than others, and you don't want to put yourself in a position that makes you vulnerable. So so they basically really no longer needed it. And the minority, about 12% she found over the course of 3 years, resumed an addiction. And the majority of those actually had a heroin problem before they went to Vietnam. So they already had some sort of habit of medicating themselves with opioids even before they went.
Nice. So that's interesting. And, you know, for people who want to follow up on the other stories, which are really key to this narrative of understanding what's going on with people who abuse drugs. You know, I would encourage them to read your chapter. But Sally, thank you so much for writing that chapter for our volume titled American Family Diaries. Thank you so much for being here.
Oh, thank you.
Hey everyone, that's the end of our discussion with Dr. Sally Satel. Thanks for watching. If you enjoyed what you saw, remember to like the video or leave us a comment, and be sure to check out the rest of our videos and research from AEI.